Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks.
Well, welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor to have Dr. Tim Kosinski on the show. Tim, thanks for being on the show here today.
Well, thank you, Philip. I appreciate it.
I really look forward to spending an hour or so with you talking about dental implants and what you're doing. But if you could tell me a little bit about yourself, you know, where you went to dental school and how you got into dentistry and a little bit about your practice, so the audience can get to know you a little bit better.
Well, sure, Philip. I'll try not to be too long-winded with this, but I graduated from the University of Detroit Mercy School of Dentistry about 100 years ago. I can honestly say I've probably been placing implants longer than any other practicing dentist in the state of Michigan right now. I've been practicing for a little over 32 years. Started placing implants in 1984, believe it or not. I am a general practitioner, and my practice is in the suburbs of Detroit. I am a affiliate adjunct clinical professor at our dental school. I'm very proud to be associated with that. And we've been doing implants a long time, Philip. We've placed well over 13,000 implants to date. And I'm proud to say that as a general practitioner. I like to say in my lectures that, I was blessed with great mentors early in my career, and mentorship kind of faded away for maybe 15, 20 years, and it's coming back. And I'm very proud at this time of my career to be able to give back as much as I can. And I appreciate the opportunity to talk to you today and hopefully share some of my experiences. And implant dentistry has changed a lot over 30 years.
It has, and I agree. You know, I think dentistry and in many ways needs good mentors, and especially with implantology, because there's not a lot of guys around like you that have been placing implants since the mid 80s. And, it's still hard to get into the implantology field. But I know when you got back into the 80s, I mean, I'm not even sure you could buy a surgical kit from Nobel at the time. So why don't you tell me about how that journey went? That had to be kind of hard to break through, being a general dentist at that time. Tell me a bit about that.
Well, I was very, very fortunate. When I was a sophomore in dental school, there was a show called That's Incredible. I don't know if some of your audience remembers that show with John Davidson and Fran Tarkington. And I remember, sophomore in dental school, you don't know that much. And there's some guy, and I'm not sure who it was. It might have been Dr. Lenny Linkow. I'm not sure. Talking about putting these metal posts in the jaw, and it made sense to me. It was like, that's what I want to do. Orthodontics didn't make sense to me. Didn't enjoy it. Implants made sense. And so I did some research. There wasn't a lot of stuff out there, but I was fortunate. One of my teachers at dental school, Dr. Paul Mentag, was the implant guy in Detroit. And at that time, most implants were placed by general practitioners. There weren't a lot of specialists placing around the country, and it was a very small, cohesive group. They started the American Academy of Implant Dentistry, and they shared information with each other. So I did my residency down in Dayton, Ohio, and worked with a implant guy down there, Frank Bastille. And taking a short story and making it extremely long for you, he passed away, but had referred me back. He knew that my wife and I wanted to move back home. And fortunately, Dr. Mentag hired me as an associate. So at that time, you're right, Branimark implants, we could not buy surgical kits. So I started with an implant called IMZ, Dr. Axel Kirsch, a long time ago. And Dr. Mentag was a phenomenal mentor. He allowed me to place and learn and develop my skills very, very early in my career. Implants have evolved since then, and more and more people have addressed it. But Philip, as a general dentist, I'm a big believer in general dentists teaching other general dentists. I think we do the best job because we share our information. We wear our emotions on our sleeve and we share that, where sometimes the specialties aren't able to communicate to us in that level because oftentimes they don't really believe that we should be doing it, that we're not really qualified or we don't really understand. So taking the knowledge and giving it back to other general dentists is very important to me.
Yeah, I agree. I have a strong passion for that, and agrees. All the great implantology courses I've taken are generally by other general dentists like yourself who have been in the field for 20 plus years and have learned from some of the greats and are passing it down. And so it's great that you had that experience. It's fantastic that you're doing that now. Tell me about your practice. You're in Detroit. And kind of tell people how you got into your practice and what your practice is like.
Well, I worked, as I mentioned, with Dr. Paul Mentek for about 5 years, and then went on my own and set up a practice in kind of the center of the city in the suburbs. And because implants were just a natural part of my life, I took a lot of continuing education. Went to the academy meetings and the international congress meetings. And I actually did my formal implant training at Harvard with Dr. Paul Schnittman. It was like weekends, I think for like a year and a half. We would travel to Boston, or I would travel to Boston. And so, we slowly evolved. At that time, 20 years ago, so if, I want to say probably 75% of my implant cases were done under intravenous sedation. I was trained with intravenous sedation. We treat a lot of physically and mentally challenged to this day, but implant dentistry was kind of a scary big deal. But as the process evolved and the tools and the science and the mechanics and the engineering evolved, it became kind of a routine procedure for most of us. And we evolved our teaching programs to incorporate and embrace this new technology. So we place a lot of implants. I don't want to exaggerate. I'm a solo practitioner, but I have a great team behind me. They're the ones that really make me look good. We place about 1,000 implants a year by myself as a general practitioner. We do have a fair number of other referring general dentists, but as time has gone on, I'm going to back up a little bit. There's two things that really changed implant dentistry. Number one, I tell people digital X-rays, right? Because all of a sudden we can double check our work in a matter of seconds. And the second thing that really changed implant dentistry is the internet. Thank God for Al Gore inventing the internet, because the public's out there and they're saying, they're typing in missing tooth hurts, tape my denture, whatever. And what's going to pop up? Information about dental implants. So even though our patients may not have extremely accurate information, they are coming in with some idea of what we're able to do to replace teeth. And it's very intuitive. It's just logical. Why not replace your teeth with another tooth? It makes sense to a lot of people.
Yeah. I mean, the whole concept of partials and dentures and bridges and all that, the more you learn about implants, the less those make sense. And so that's why it's so exciting for me, is that this solution, really makes a lot of sense on a lot of levels, and it's continuing to get better and better all the time. For the podcast today, we want to kind of cover some of the bread and butter about single implantology, because that's what most of the GPs do in their office. 80% of the implants placed in America today are probably, one at a time. So, what's your kind of diagnosis and treatment planning look like for single cases, whether it's, anterior or posterior? How, someone walks in and they're missing a tooth, or they're in your office and a tooth has to be taken out. What's that diagnosis and treatment planning look like in your office?
That's a great way to start. When a patient comes to my office, they may or may not have some information, but they're obviously missing something, or they broke something, right? There's a root in there. And I like to begin my conversation with the patients, if you don't mind, if you can indulge me for a minute. And I introduce myself as I just introduced myself to you. And then I tell them about dental implants. And I tell them, you may know a lot about dental implants. You may know very little, but I want you to hear it from me. And this is exactly what I say to every new patient who comes to the door. A dental implant is a piece of metal made of titanium I'm going to do this kind of fast. Titanium is a biocompatible material. It's a big $5 word. That means the bone actually grows into the surface of the metal and becomes a permanent part of your jaw and allows us to anchor something to it. It could be one tooth, it could be several teeth, it could be all your teeth, it could be a denture or a partial. Bone is alive in the body, so it constantly changes over. And I'll usually touch the patient's arm and say, if you break your arm, you're in a cast for 6 weeks, and it mends. Well, that's exactly what happens when we put this little spark plug or screw in your jaw. The body's cells will actually attack it and eat away the bone. And then different cells, we know those as osteoclasts, I don't say that. And then different cells will lay down new bone. We know those as osteoblasts. So this is a process. And when this process works, we're able to give you back a tooth. However, there's two important criteria for people who want implants. Number one, you have to be relatively healthy. No uncontrolled medical problems like uncontrolled diabetes, uncontrolled hypertension, immunosuppressive diseases like AIDS and things like that. I tell people, if you cut yourself shaving or you're gardening and you cut yourself, if you're normally a good healer, you're probably going to heal well. If you're a slow healer, you're going to heal slowly. The second criteria is we have to have enough bone to be able to place something into it. And I think that so if that's where most GPs, as they're developing their confidence or a lack of confidence, are reluctant to place implants because they're worried about anatomy, right? They're worried about the nerve or they're worried about the sinus. And we can talk about that afterwards, how we deal with that. But the surgical procedure, I'll tell my patients, is fairly routine. Obviously, it's not routine for the patient at all, but it's fairly routine for us. We numb the gum, and I don't block anybody. It's all infiltration. We know that bone, that bone is not innervated. Bone has no pain receptors in it. Nerves run through bone, and we have to be careful that we don't damage or bruise a nerve. But the only thing that the patient could experience is tissue. So all I do is infiltrate the tissue. Then we have a series of drills, 1, 2, 3, sometimes 4, and it implants like a spark plug that's threaded into the bone, buried underneath the gum tissue, and it has to heal for a period of time. All our implants are internally designed. So after healing, we'll make an impression or a negative, whether it be with our computer or with the goop in the mouth. And the laboratory, like Glidewell Lab, will fabricate what we call an abutment. And I like that. That's a funny word, abutment. What's an abutment? And I'll say it's like Abraham Lincoln's top hat. It'll be engaged into the implant, locked in, and then the cap or crown is glued or cemented onto that. And when these implants are placed, we have an incredible success rate. But every once in a while, an implant doesn't heal the way we want it to, not keeping it clean or engineering or smoking. Or sometimes we don't know why an implant doesn't work. It could be the implant or surgical technique or changes in biochemistry or hormonal changes. But if an implant doesn't work today, we're normally going to know it during that initial healing period, and we can replace it. That is my very brief 5-minute conversation with my patient explaining what we're about to do to them. So it takes a lot of the anxiety and mystery out of a procedure that 20 years ago I would sedate my patients and it took an hour and a half to put a single implant in. So we now have the ability to really benefit our patients. Costs have come way down. The time we spend is way down. The engineering, the materials we have are so much better. It's an incredible time to be a dentist.
Yeah, I mean, I think you did a great job with that, breaking it down to where you're just getting the understanding of the whole steps. So it takes the fear of the unknown out of the way. And the fact that we don't have to sedate people anymore lets them know that, hey, this maybe isn't a scary deal. And time in a chair is less than it used to be. So that's better for everybody. So yeah, it's come a long way over time. So, most patients are coming in with a missing back tooth maybe, or maybe they have, a tooth that's still there and broken. What's your go-to kind of site preparation? A lot of implantology sometimes that I do is someone comes in with a non-restorable tooth, and they want another tooth. What's your process for getting teeth out and doing a good socket grafting? Because that's obviously probably the first step someone takes in grafting is socket grafting. That's the easiest, most predictable way. And probably the best place for a beginner to start. How are you doing that in your office?
Thank you for bringing that up, because I think we get so caught up in putting this little screw in the bone that we forget that we have to prepare the bone. And my wife likes to garden. And in Michigan, we have a very short summer. It's probably the same where you are. But in the springtime, she works very hard preparing the garden site so that we can have beautiful flowers in August and beautiful vegetables in August. And so site preparation is very, very important. I'm a big believer, and if you've seen my YouTube videos or my articles, I'm a big believer in atraumatic extraction. And you're right, people are coming in with non-restorable teeth, fractured, decayed, or whatever, and we have to look at that very carefully. So atraumatic extraction, what does that mean? It means removing the tooth and trying to maintain as much bone as possible, right? Our bone is gold to us. And if we can remove that tooth and create a socket where all the walls are intact, we have a tremendous advantage. Now, sometimes we will lose the facial plate of bone, and we can address that if we get into a little more complicated situations. But basically, if we remove a tooth atraumatically and we maintain all the bone, we have a cereal bowl. And we can pretty much put anything in that cereal bowl to grow bone. Remember, bone is alive in the body, right? No matter what we put in the socket, it's going to be eaten away by osteoclasts, and new bone is going to be formed by osteoblasts. So whatever we put in there, we're not pouring concrete into a hole where it's getting hard. It's actually going to change over. So what the general dentist, what our colleagues need to realize is we have to determine whether or not we should prepare the site and grow bone and prepare the site for a future implant, or oftentimes, and I love to do immediate implants, meaning I take a tooth out and I place an implant immediately. But to do that, we have to have initial stability, and we have to extend beyond the socket by at least 2 millimeters. An implant has to have initial stability to integrate properly. We also, and I know we're going to go into anteriors in a little bit, we also don't put the implant directly into the socket, because oftentimes the socket is not the best place to place an implant. We have to engage palatal bone or lingual bone to some respect to create that initial stability. If we do an immediate implant, I will prepare my osteotomy site with whichever system you're using. I will then put my graft material, whether it be allograft, which is human bone, or alloplastic material like tricalcium phosphate, or even a product called Osteogen, which I love. And for your listeners, you should at least Google that name. I get nothing out of it. Osteogen. It's just a wonderful material that will transform into bone in a very few short months. Anyways, we will place that implant and then bury the implant and allow it to heal. So the thing that we have to be conscious of is anatomy. And the lower jaw, we're concerned with the mandibular nerve, and the upper jaw, we're concerned with the sinus area. So the determination of whether to graft first and place later or do it all at one time is dictated by the amount of bone that we have.
Yeah, so in an ideal scenario, if there's large amounts of bone in a healthy patient and good tissue, an immediate implant might make sense. But if there's inadequate bone due to lack of socket and major disease, or an extraction breaking off buccal plate, or inadequate soft tissue, then in an unhealthy patient, perhaps a two-stage approach would be best.
And oftentimes people will say, well, what if there's an infection, right, an abscess? Well, we don't put immediate implants in infected sites, but we can graft in infected sites. And I like to use the analogy of, I don't know if you've ever had a hangnail on your toe. It's a horribly painful thing, and it usually happens when you're on vacation. You can barely walk. And what do? You go home, you soak your foot, soak your foot in a while, you clip it, and in 5 minutes, you've totally forgotten that you even had that discomfort. The body is an amazing thing. It will heal wonderfully, but our graft material must be protected from invagination of epithelium. And so socket grafting may sound very routine and basic, but it can be complicated, and we really have to understand the process. A socket heals, whether it's grafted or not, from the apex towards the crest. So we have to protect the crest from invagination of epithelium, and epithelium can grow 10 times faster than bone. So if we're going to properly graft the site in preparation for an implant, or for whatever reason where we don't want bone to shrink, we must protect it with a membrane. It's a whole nother lecture that we can discuss, but I do a course at the University of Detroit Dental School on live patients. We actually, our doctors will see up to 80 patients on a Saturday, and we actually do extractions and grafting and membranes. We work with 3 different types of materials. We work with 2 different membranes. We're even taking roots from our patients and doing dentin grinding and using the patient's own root structure as our graft material. And we do that all on a Saturday at our dental school on live patients. So for some of your audience, maybe you really want to get proficient, the best way to learn is on live patients. And that's a wonderful way to get a head start on proper grafting techniques.
Yeah, I mean, I think I tell people the best thing to do is to get really good at grafting and extracting, because that's going to make your surgical skills that much better before maybe you even start implant placement. So, learning how to handle graft material, learning how to handle the tissue, learning how to clean the bone and shape the bone, that's a good introductory to implants, and especially if someone's conservative. So definitely makes sense at times. Definitely a good way to ease into some of those, but sometimes an immediate implant is necessary. So you like to prepare the osteotomy, then pack the bone, and then place the implant around it. Is that right?
Yep, I thread it back in, and that way the implant itself will actually push the graft material against the walls. The literature is pretty clear. If we have a gap between the bone and the implant of 2 millimeters or less, the literature will say you don't need a graft material. But if it's greater than 2 millimeters, then you have to protect it, because physiologically the bone is going to shrink, right? That's what bone does. You remove a tooth, the bone is going to shrink down and in or up and in. That's what it does. Another thing that I'll tell my patients, because patients will go, why do you have to graft? Because, number one, grafting is a really good financial motivator for our practices. It can be a simple thing, and it can be very lucrative for us. But let's say you have a molar tooth and you're worried about the sinus and you're going to take the tooth out. Well, you have to pack something in there. And I'll use the analogy, and it's a great analogy for those of you who want to listen. I'll slow down a little bit. A tent pole holding up a circus tent. The root of a tooth is like a tent pole holding up a circus tent. What happens to the circus tent when you remove the tent pole? It collapses. And that's what we see in our practices, right? We'd love to put an implant in a first molar area. There's not enough bone. So we get nervous. Then we send to our specialists that have to do, sinus augmentation and all these very expensive procedures to our patients, where an ounce of prevention would have given us a site that we could easily place an implant in the future ourselves.
Yeah, I think I try to graft every tooth I extract in the mouth, unless it's a second molar and the patient tells me I'm never going to come back and implant in that site. But I routinely try to graft and membrane every tooth I take out, so that even if the patient doesn't want an implant, we've got a good ridge there for a Pontic, or in case they change their mind or the financials change later, we still have that bone there, because once that bone and anatomy is gone, it's a lot harder to get back.
And we've all seen it, right? We've all seen the horse's saddle in the posterior. We've seen the concavity in the anterior. It can be very frustrating. You're right. Yeah. Great advice.
So let's say that we were able to get an implant in. What's the best way to restore in the posterior? Are you looking at scanning? Are you looking at traditional impressions, or how are you restoring? Obviously, there's a resurgence of screw retained crowns. What's your material choice? I mean, walk somebody through a posterior implant restoration. It's not just send to the lab and say make crown. There's and
yeah.
and when placing implants, you have to be thinking with the restoration in mind. I mean, I'm always thinking, okay, what's my end goal? Where do I want the tooth? Okay, now where do I want the implant? Now, how am I positioning this? I mean, kind of walk somebody through what they should be thinking when placing the implant, and then what that kind of looks like when they restore it.
Man, you're hitting it. That's awesome. You're hitting it right on. I learned a long time ago, early in my career, that we need to visualize the case finished before we ever start. Placing implants is fun, it's financially rewarding, but we have to understand the prosthetic design. Implants today are prosthetically driven. And that's why I'm so in tune with a company like Glidewell. I don't know if you want me to say
sure.
A brand name.
Yeah, absolutely.
But I started working with them early on when they developed their first tapered implant. I was in Vegas at a meeting, and I was called to Jim Glidewell's suite, and they were talking about this concept of inclusive implants. So what does that mean? Well, Glidewell was the first company, in my opinion, that was more concerned with the fabrication of the prosthetics with the crown than they were in selling implants. Every other company before that, they wanted to sell you implants. And as you said, make crown, right? That's what you said to the lab. Well, they saw enough problems. It's a big enough lab where implants are improperly placed, improperly positioned. And it made their job more difficult, and it made it much more expensive for us. So I'm a big believer in that if you are able to visualize the case finish before you ever start, your implants can be ideally placed. They can be center, mesial distal. They can be along the central groove area. And, as a general practitioner, we don't have to do every implant that comes to the door. But I think I challenge general practitioners to know that it is something that they should be doing in their practices because their patient wants them to. We have specialists to help us in more difficult situations. But, going back, I think it's important that you look at mesial distal dimensions. You have to look at buccolingual or buccal palatal dimensions. You have to look at interocclusal space. And all those three things are going to determine what type of prosthesis you're going to make, whether it's going to be an abutment and a crown, a cement-on crown, or if it's going to be a screw retain. If we don't have a lot of interocclusal space, 5 millimeters or less, then we're going to design it with being a screw retain prosthesis. I do a lot of custom abutments. I'm not a big stock abutment guy. And, I've been doing this long enough, Philip, that things change. I always say that, bell bottoms came back twice in my lifetime and will probably come back one more time. So what was old becomes new and then it fades away again. I was never a big stock abutment guy because a stock abutment is a round circle that's subgingival normally. It's some part in the edentulous space. And so I like custom abutments, and everything today is made CAD/CAM. It's all designed CAD. It's all done by a computer. I can look at every case before the lab ever processes it if I wanted to. So all of my margins on all of my crowns are at or just slightly subgingival, And cement cleanup is not a problem anymore because I'm not going 2-3 millimeters subgingival where you can't clean cement. And that's why screw retain has become popular again, is because our periodontist colleagues are saying, you general dentists are all idiots and you're causing these implants to fail because cement's getting caught underneath it. And they're right. So we can correct that with a high quality lab that knows what they're doing. But it's not a technician painting porcelain on anymore or milling something. It's all CAD/CAM design. It's just wonderful technology. So me personally, and that's what you're asking, is I place the implant and I will either do a digital or conventional impression with polysiloxane materials. What I use is based on what my staff has ready for me, how convenient it is, and there can't be any bleeding with our digital impressions. We use a 3M True system, which is wonderful. And obviously the advantage of that is we press a button and 4 days later I have my abutment crown, which is pretty cool technology. Or what I do in my practice, and again, I'm kind of old school, right? I mean, I know a lot of people are making their own abutments in the office. I don't have time for that. Or take a polysiloxane impression. I will use a closed tray most of the time, but if I have implants on either side of the arch, let's say 19 and 30, then I will try to use an open tray. Or if I have implants that aren't parallel to each other, I will do an open tray. meaning that we have a screw that goes through the impression. And you know what's a really nice product to do that with open tray are called Mira trays. I don't know, Philip, if you've used those. MIRA trays.
Yeah, I've used those. They're great. Yeah.
So, and then the laboratory will make, like Glidewell Lab will make a custom abutment, either titanium or zirconia. Usually zirconia in the aesthetic zone, titanium for strength in the posterior. And they give you a seating guide that you can torque. One of the most important things that I think, and it just happened 2 times today, as a matter of fact, we get a lot of referrals from other offices where, doctors will put an abutment and cement a crown, and the abutment will come loose over time. That can be very, very challenging. You have to know the torque requirements for each implant system that you use, because every screw is unique. And like with Glidewell, it's 35 Newton centimeters. You need to torque it to 35 Newton centimeters, and it won't come loose. But as general dentists, we have a tendency to baby it. Maybe we don't torque it quite as tight as we should. We're afraid or whatever, and that creates a problem. One other thing that I've always done in 32 years, and I know other speakers have poo-pooed me, I've always put my implant crowns in with soft cement. So I didn't say temporary cement, I said soft cement. And that allows me to get back to the body of the implant if something goes wrong. An abutment comes loose, food's trapping, they're biting their cheek in the past, and porcelain chipped. And I was just reading an article from Dr. Tarnow, and in his literature, 52% when you have an implant next to a conventional crown in the molar area, 52% of the time that contact will open, that tooth will migrate. And that's frustrating, right? It becomes a food trap. So we have to be aware of all these things before we ever start. We have to really understand all of it before we ever start.
Yeah, you covered a lot of good points. I like screw down, but only if I have a custom abutment milled and it's basically cemented at the lab, and then I just screw it in. I'm not afraid to do cement retain because, like you, I only do custom abutments and put that margin, right at the gum line or 1 millimeter above and cement it that way. So you've just got to think of those things ahead of time and, have good lab communication and, try to avoid the mistakes before they happen as opposed to, having the mistakes happen and then trying to backtrack, because the technology allows us to kind of workflow around some of these things nowadays. And, people should be taking advantage of those, appropriately.
I don't know who your audience is. But it's for the less experienced dentists, younger dentists, I think we have to take advantage of the technology we have today, and working with these high quality lab technicians, and they're just brilliant digital designers. We can really idealize these cases before you start, and sending a model or sending a design to them can really assure that we're going to get the best result we can. Now, I teach a program in my office where I let doctors come in and they actually place implants in my patients under a very strict protocol, under direct supervision. And we do it 2-dimensionally with radiographs. But we go through a lot of steps. And again, digital radiographs allow us to do this to ensure that we get proper mesial, distal, buccal, lingual positioning, and also proper depth, where we're not concerned with harming the patient by damaging vital anatomy. However, CBCT analysis has changed all of that, because we're able to visualize the edentulous space in 3 dimensions now, and that helps us in determining which cases we want to do or not do. And we can even take it further with our software. We can virtually place an implant using the computer before we ever start. So it kind of makes us all equal. My experience versus somebody who's inexperienced, we now have the ability to virtually place an implant. We're going to know what size, shape, type of implant, and it'll even help us in positioning of the implant, which really, I think, has improved our ability to provide really incredible service to our patients.
Yeah, with the technology, and if you're teaming up with a good lab tech, working with a good company that helps you with your support. There's unlimited resources that can really ensure that the care is done right and the outcome is meeting the goals desired. So you can do the surgery on the software, then you can do it in your mind, and you do it on the patient, and in the lab, so you've done it 3 or 4 times, and so it really helps get those outcomes better. Talk with us a little bit about anterior cases, because anterior cases are a little different. You're probably doing more immediate implant placement in the anterior zone to preserve bone and gum tissue. So how are anterior implants surgically and prosthetically different? Because the rules change a bit in the anterior.
Hey, you're absolutely right. In our courses, I strongly recommend to my participants that they place 20 posterior implants before they ever go to the anterior. Because, you can make a little mistake in the posterior and it won't affect the patient. You could make a little mistake in the anterior and affect the patient forever. And so you are correct. It's a little bit more difficult. I'm a big believer in emergence profile and what we call smile design, right? We're looking at the smile. We're trying to maintain interdental papilla. I mean, that's important. We all see people, right? Even if we go to a movie where a patient, somebody has nice teeth except one really big square tooth. It doesn't look natural. And a dentist did it. A laboratory technician fabricated it. Well, why is that? Well, they're filling a space. And again, going back to what we said earlier, that you eloquently said, it's really important to understand the end result before you start. And it all goes back to, if we have a broken tooth, to atraumatically remove that tooth. If we can maintain facial plate of bone, it gives us an advantage, number one. Number two, we want to maintain the interseptal bone. The interseptal bone is what holds the interdental papilla. If we don't have interseptal bone, we will not have interdental papilla. And our periodontist colleagues can certainly do all kinds of pregingival grafts and all of that, but they'll tell you that without bone support, that tissue is going to shrink over a period of time. So maintaining that bone is critical. When we're placing our implant, let's for example, let's talk about a central incisor, right? Tooth number 8, we're removing it. We remove the root. We kept the facial plate of bone. We maintain the interseptal bone. Our implant, our osteotomy, is not going to be in that socket site, because we have to realize that the bone in the premaxilla can be extremely thin. It can be paper thin. And so our implant position for aesthetics is about 3 millimeters palatal to the facial aspects of the adjacent teeth. So I'm actually engaging the palatal bone. I'm not going back into the socket. That's the biggest mistake that doctors make. Why is that? Well, because I have to have room to create a custom abutment, and then I have to have room to create an aesthetic crown with emergence. It's also important to realize that the proximal contacts should be about 4 to 5 millimeters from your margin. We used to say from the body of the implant, but with our platform switching, it's really the body of the abutment itself. And if we can keep the distance between the margin and the proximal contact to be 4 to 5 millimeters, our interdental papilla gravity will bring it down, and we will create triangles. I know that's a little bit complicated to discuss, but certainly if you look at the literature and you look at some of my articles even, you'll see that this is pretty predictable. Can we always do that? Well, no. Sometimes we have big defects in the anterior maxilla, and we can create aesthetic problems. But again, it's important that we discuss that with our patients beforehand. Sometimes teeth can be very long into the gingiva because that's the anatomy that we have. And if it's not acceptable to the patient because they have a high smile, well, in that situation, I would refer to my surgeon who would do a block graft to try to give us more bone to work with. We can use pink porcelain, gum-colored porcelain, all of those things, but we better understand it before we place the implant rather than after the fact. It's too important.
Yeah, there's a lot of criteria to remember, and then you've also just got to look at how much facial bone do you need in case the bone collapses, you talk about that 2 millimeter gap. You want to place it palatal so that you're creating and stabilizing more facial bone, because that facial bone is more likely to recede, and you're more likely to lose bone and expose threads. You've got papilla issues to deal with. You've got contact issues to deal with. You've got emergence profiles issues, and all that. You haven't even talked about what type of material choices to start with yet. You're probably talking more of a titanium to zirconia abutment choice up there. Sometimes, cementing is the only option in the anterior based upon the angulation. I mean, so your choices become narrowed down by some of the anatomy, and the anatomy is kind of the tricky part in the front part.
Exactly. You're absolutely right, and it can be a challenge. But again, with the help of CBCT analysis, virtual planning, you're going to know a lot of that stuff beforehand. And that, like Glidewell, does that for me all the time. And I can sit and I, obviously, maybe some of the more computer literate people out there can do it themselves, but I let the techies do that, right? And I can actually show the patient photos. I go, look, this is going to be a little bit longer here. Or, if we do this, this is why we're doing things. When I started, patients should have been happy that we were able to put implants in bone. And the prosthetics were the prosthetics, and they were lucky. We also put the longest, fattest implant we could in every situation to increase the surface area. That's not what we teach anymore. We want less titanium, more bone. So in the anterior, every one of your listeners have seen an anterior implant case where it's gray at the gum tissue, and you feel bad for the patient. So you want, as you mentioned, you want that thickness of bone. So less titanium, more bone. Why can we do that? Is because the materials are better engineered. Implants don't break, they don't crack. Abutments don't come loose if we torque them correctly. The problems that I had early on in my career have been resolved to a large extent. When I started, everything was screwed in, nothing was cemented, and then we changed everything being cemented, and now we're going back to more things being threaded into position, and that's the desire of the doctor and the choice of the doctor.
Yeah, but exactly like you're saying, the patient expectations have changed. We can't just put an implant in and call it good anymore. We've got to almost recreate what nature did perfectly, and that's a hard thing to do. So that's why I think you said it, at minimum 20 in the back before you even start in the front, and doing that CBCT planning with a skilled technician and having those conversations with the patient are critical, because one small mistake could lead to a big problem, and then your patients are dealing with that problem right in their smile zone for a long time. So definitely a lot to consider up there. So what's your material of choice in the anterior for crowns? Are you liking Emax or zirconia? Obviously, there's a lot of options out there.
Yeah, I guess what we use, I love the Bruxer crowns, and the Bruxer anterior aesthetics materials have proven to work very well. When we have teeth of varying shades, then I will use a zirconia abutment and then Emax on top of it, because of the aesthetic staining and those type of things. So in the anterior, I do a lot of Bruxer in the posterior. In the anterior, it all depends on the patient's color, and what we want to mask, from that point. So the Bruxer anterior aesthetic and Emax, and most of the time zirconia abutments in the anterior, from cuspid to cuspid, and then titanium in the back.
Yeah, I agree. I think having that titanium in the back's great. The zirconia abutments up front allow us the opportunity to hide the metal and give them a wonderful smile. And the if you design them and have them milled properly, then the strength isn't an issue anymore. I don't think the failure of the material and the screws is our concern anymore. Like you said, I think it's more adhering to the right principles of biology and getting the surgeries correct that that really is where we get ourselves into trouble. And then we try to overcompensate with things when we don't, to cover our shortcomings with some of those surgeries.
I think that, and sometimes with titanium abutments, they can gold plate them too, which warms it up too. Sometimes you need that strength of a titanium abutment in the anterior, bruxers and things like that. One thing I didn't mention, when we're doing, and I think it's important for your audience, when we're doing an immediate implant into a socket, physiologically, it's imperative that we bury that implant a millimeter into the socket. Normally, we place our implants to the crest, but physiologically, we know nature, if that bone's going to shrink to some degree, so you want to bury that implant a millimeter into the socket whenever you're doing an immediate implant. I just wanted to mention that.
Sure, yeah, and I think that's a great thing to cover because the crestal margin of that bone is going to collapse a little bit. So you have to account for that by burying it deep. Now, you don't want to put it 4 millimeters deep. I mean, obviously, there's a there's a balance there, but I think slightly subgingival, and I believe that's how most of the implant systems are designing their implants is for slight subgingival placement, regardless. So that can definitely fill in line with the implant protocol as is, but definitely important for the immediate placement. So I know we've talked about a lot here, Tim. Is there anything that kind of we need to cover for the basics here? We've talked about how to place and restore posterior, and we talked about how to place and restore anterior. Obviously, you've placed a lot of systems in your time. What implant system are you placing now, and why are you using it?
Well, you're right. I've used a lot of systems, and you have to remember, Philip, that I'm an educator, as you are, and so we have an advantage to investigate and document a lot of systems. I've used most of the systems over the years. Dr. Jack Hahn is a dear friend of mine and one of my mentors, and he was the inventor, as you know, but maybe some in your audience don't know. He created the Stereos Replace implant, which was purchased by Nobel Biocare, which became their biggest selling implant. And so I have a lot of respect for Jack. And when he created the Hahn implant, H-A-H-N implant, which is now distributed through Glidewell, I jumped on it because I know how brilliant he is and the science behind it. It is a very aggressive implant with very, very great threads, micro threads at the crestal region, and a machine bevel collar at the crest. And, he's placed many more, probably tens of thousands than I ever have. And, in his research, he found that, bone shrunk around implants, right? We got that bowl, and we used to say, well, it's normal to get shrinkage 1 to 3 mil from the first to maybe the third thread was normal in the first year. Well, that's just not the case anymore, because that really messes up our aesthetics and our function, and then we're criticized. So the design of the Hahn implant has proven to be wonderful. And as a matter of fact, we've placed about 2,000 of them now. And my daughter, Jessica, runs my office. And she did a research project several years ago through NYU. And she is investigating. She's going back and bringing all those patients back. And we're going to determine the quantitatively how bone has changed around those implants. And preliminarily, we're seeing just amazing results with this implant. It's platform switched, meaning our abutment to implant connection is inside the implant. So we're trying to trick the body, trick the bone into realizing that there is no micro gap there, so we don't see bone shrinkage as we had in the past. So that is my favorite implant right now. It's very versatile. They have a guided kit that is just phenomenal because everything's pre-measured. I don't need keys. So if you're going to pin me down to one system, that would be my favorite. And you said your audience is general practitioners. What's very important, you have to remember, I'm in Detroit, right? Detroit was probably the hardest hit economy in the whole country in 2008. And I'm just one general dentist in the suburbs, and we place a lot of implants. There's a lot of need out there. There's a lot of desire. What motivates people is often budget. As we began our conversation, I said that, 20 years ago, 75% of my patients were sedated before we placed implants. That's not the case anymore. It can be a 15-minute procedure in my hands today. So I'm able to reduce our fees to make implants accessible to our patients. And I think the general practitioners out there, you asked me, well, how are you doing so many? How did you get started? Well, I think that cost can play a factor, and the time. It's not only the cost of the procedure, but it's also the time away from work. People can't take time off of work like they used to, So their time is very, very valuable. So when you're working with an implant like Hahn, where Glidewell will tell you precisely what everything is going to cost, the implant, the drills, the healing abutment, the transfer assembly, the analog, if you want to do a temporary abutment, the temporary crown, the final abutment, whether it be zirconia or titanium, and the final crown, whether it be Bruxer or Bruxer Anterior or Emax, if you know what that number is, it gives you a tremendous advantage. And another thing I'm not selling because I have no financial interest, they also give you 20% off the restorative when you restore a Hahn implant. That's incredible savings in the course of a year, So, I don't like to tell people what system they use because most systems work very well today. But you asked me a specific question. I hope I answered it as specifically and apolitically as I can.
Yeah, no, I think that's great. I've used a lot of systems. I actually purchased the Hahn guided kit when it came out, and I've done some guided cases with it. I've done some freehand cases with the Hahn kit, and I actually have really enjoyed placing that implant. I, for one, really like the aggressive threads because primary stability is a big thing for me, and the ease of compatibility and restorability with that implant to me is fantastic. So I'm very encouraged with it. I would encourage everybody to at least try it if you're placing implants, and obviously anytime you can know your costs and help build that into your practice plan, I mean, that's got to be something you're doing. I mean, we have to keep, one eye on our cost as a business owner, and then, also deliver a quality product to our patients. So,
yeah, being from Detroit, being from Detroit, USA made is important to my patient population. Made in Detroit, made in USA. The lab is in California. Everything is CAD/CAM designed. So that's very impressive to our patients. That's what they want to hear. That's what my patients want to hear. And, I do a lot of teaching for them. I have a great 2-day program. And I don't get involved with the registration or anything like that. But I think if you come to one of my programs, they actually give you a surgical kit and 5 implants as part of the cost of the tuition. And that's a great deal. So, if you're interested, I think it's worth. I do a lot of teaching, elsewhere, but I think it's certainly something your audience, if they want to learn, it's a great program. A lot of practical stuff from one general dentist to another general dentist.
Yeah, and that's what I like about you and others that are in your category. It's okay. I've got to practice. I do this day in and day out. I've got to make payroll. I've got to be a business owner. I've got to make a profit. But I also you have also been in the field for 20 to 30 years placing implants. You know what it takes to have predictability and success and clinical outcomes. So you're sharing all that experience with people that, could really glean from that and acknowledge, the successes and failures that maybe have gone on through that time and, utilize it in a way that best serves their practice. So if somebody was looking to come take a course from you, obviously they can sign up through Glidewell being one of them. What course would you recommend? Is it your surgical placement of implants? How many courses are you teaching and how should they come see you?
We do 6 courses a year for them. They're 2-day programs. We do 3 in Newport Beach, California, which is beautiful. And then they scheduled me 3 in different cities. We've done Cincinnati. I'll be in New Jersey next month or beginning of November. I can't remember. We have programs at our University of Detroit Dental School, as I mentioned, on atraumatic extractions and grafting. I'm also involved with the Engel Institute out of Charlotte, North Carolina, where we do live my patients. The doctors are able to come to my office and place implants on my patients, as I mentioned, under a very strict protocol, under direct supervision. Great way to learn on patients. So we have a lot of things going on. I'll be at the AGD in New Orleans next year. Very excited. We're going to do a day program, and then we're going to do a program on cadaver heads at the dental school there. So we have a lot of interesting things coming up in 2018, and it's an exciting time to be a dentist. It really is. And all those GPs out there who listen to you, you got to get involved. You just have to. It's silly not to. You can't be referring this work out. You just can't.
Yeah, I think it's important for general dentists to get involved with the implant study club or some of the academies and take some courses. And even if you're not going to be doing the vast majority of surgeries at your office, or even if you're not going to be doing a lot or any surgeries, I think you need to be well informed. You need to be diagnosing it. You need to be part of the implant game, because that portion of dentistry is only going to continue to grow. And I feel like you're going to be kind of missing out on probably some of the better parts of dentistry in today's era if you're not in that game. So I will direct people to some of your resources and help them get in touch with you. So going to the Engel Institute, seeing you there, they can see you at the Glidewell course, so they can catch you in a meeting. And I'm sure you could have a lot to teach and share with these implant practitioners.
Thank you. Yeah, it's great. Implants are the hottest thing out there. It's the most financially rewarding thing that you can do in dentistry today. So I agree with you completely. I repeat what you said. It's a fun time to be a dentist. It
is. So with that, Tim, I'll let you get back to your drive. I know you're commuting for a weekend away here from our busy dentistry lives. Any way that people should get in touch with you if they want to? I know your work and do a lot. Is Glidewell Direct the best way to sign up for a course?
Let me give you the office email address.
Okay.
And that way that they can communicate directly with my team and my staff. And I'm very good about returning emails. Quite simply, it's all questions, ALL questions, at smilecreator.net. All questions at smilecreator.net. And I'd be happy to share anything with any of your colleagues, your listeners. We want to grow the profession. It's as I said, I appreciate being able to mentor at this time of my life. It's a lot of fun, and I appreciate what you're doing, because I know you're taking time from your busy schedule too. So I don't know you personally. I'm sure we're going to meet up someday, but I respect how you're advancing the profession too. That you should be complimented.
Well, great. I appreciate that. Yeah, I look forward to meeting you. I know I've only read and heard great things about what you're doing, so looking forward to catching one of your courses somewhere. And until then, I wish you the best of luck and really appreciate you spending some time with me on the show, and look forward to seeing you soon.
Thank you, Philip. I appreciate you.
All right. Thanks, Tim. Bye-bye.